This podcast is brought to you by the blast cell, the unruly adolescent of the bone marrow. In a healthy system, our blood cells are born and mature gracefully into adulthood. But in the wild world of acute myeloid leukemia, these blasts are the cellular equivalent of teenagers who refuse to grow up. They are large, opinionated, and defiantly refuse to segment into their proper working roles, instead choosing to multiply uncontrollably and take over the entire bone marrow. It's a rebellious and ultimately chaotic occupation of the body's most vital factory.
Welcome back to the Deep Dive. Last time, we explored the world of benign myeloid disorders, the body's appropriate and sometimes overly exuberant response to infection and inflammation. We talked left shifts, toxic granulation, doly bodies, all signs of a healthy bone marrow kicking into high gear.
Exactly. That was the story of an army being called to action. Today, we cross the line. We're moving from a controlled, reactive process to something much more sinister. We're talking about a rebellion from within. This is the start of our journey into myeloid neoplasias.
It's a huge and complex topic, so we're going to break it down. Myeloid neoplasia is this big umbrella term for cancers originating from the myeloid stem cell lineage in the bone marrow. These are clonal diseases, meaning a single rogue cell has a genetic mutation that leads to uncontrollable cell division.
And under that umbrella, you have a few major categories. You have the myeloproliferative neoplasms, or MPNs, where the cells mature, but there are just way too many of them. You have the myelodysplastic syndromes, or MDS, where the cells are being made, but they're abnormal, they're dysplastic, and they don't function properly. And then you have the big one, the most aggressive of the group, and our focus for today, acute myeloid leukemia, or AML.
It's the textbook example of a malignancy that is both proliferative and, crucially, has a block in maturation. The bone marrow factory gets stuck. It can't produce finished functional cells. Instead, it just turns out endless copies of the most immature precursor cells, the blasts. And that is where the whole story begins. So, let's start with the absolute fundamental definition. What, at its core, is AML?
The World Health Organization has drawn a very clear line in the sand. For a diagnosis of AML, you need to find that 20% or more of the nucleated cells in the bone marrow are myeloid blasts. There are a few exceptions with specific genetic markers, but that 20% blast count is the universally recognized threshold. It's the cutoff that separates the less aggressive syndromes like MDS from full-blown acute leukemia.
It's such a critical number, and it leads us directly into the pathophysiology. Why does this happen? We said it's a genetic mutation, but what is that mutation actually doing to the cell to cause this catastrophe?
It's a double-hit problem, really. The underlying genetic mutations do two terrible things. First, they give the cell a survival and proliferation advantage. It starts dividing when it shouldn't and refuses to die on schedule through apoptosis. Second, and this is the key to AML, the mutations cause a differentiation block. The cell gets frozen in its immature blast stage. It never receives the signals to mature into a functional neutrophil or monocyte.
So you have a factory that's not only overproducing, but it's only making defective, unfinished parts. It's making engine blocks, but never putting them into cars. And soon, the entire factory floor is just filled to the ceiling with these useless engine blocks, and there's no room for anything else.
That is the perfect analogy. The bone marrow becomes packed, hypercellular, with these useless, immortal blasts. And this overcrowding is what causes all the clinical symptoms. The blasts physically crowd out the normal hematopoietic elements. So what happens?
First, they crowd out the erythroid precursors. Production of red blood cells plummets. The patient becomes anemic, leading to fatigue, weakness, pallor, and shortness of breath. Then they push out the megakaryocytes, the platelet factories. Platelet production craters. The patient develops thrombocytopenia, and they start to present with bleeding gums, nosebleeds, easy bruising, and petechiae.
And finally, and most dangerously, the blasts crowd out the normal granulocyte production line. While the total white blood cell count might be high due to circulating blasts, the number of functional mature neutrophils is often critically low. This neutropenia leaves the patient profoundly immunocompromised and susceptible to overwhelming infections. Fever is one of the most common presenting symptoms for this reason.
So really, AML is a disease of bone marrow failure caused by this malignant overcrowding. The symptoms aren't caused by the blasts themselves, but by the absence of the normal cells the blasts have replaced. And this whole devastating picture starts for us as medical laboratory scientists with one thing: a CBC that lands on our bench.
Let's walk through that CBC printout. The first things you'll probably notice are in the red cell and platelet lines. The hemoglobin and hematocrit will be low. The platelet count will be low, sometimes profoundly low. That's your anemia and thrombocytopenia, right there. But then you get to the WBC count.
And this is the tricky one, because it can be anything. It can be low, leukopenic, the blasts are mostly confined to the marrow. It can be normal, or it can be sky high, in the tens or even hundreds of thousands if the blasts have spilled out into the peripheral blood. The key takeaway is not to be fooled by a high WBC. It's a leukocytosis comprised of non-functional cells. The absolute neutrophil count is what matters for infection risk, and it's usually very low.
And then comes the flag that changes everything. The analyzer's differential flags for blasts, immature granulocytes, or give some other indication that there are abnormal cells present. That's our cue. That CBC result is a stat call to the clinician, and our absolute priority is to get that smear under the microscope.
This is where the MLS's morphological skill is paramount. You are the first human to lay eyes on these malignant cells. So what are we looking for on that peripheral smear? What does a myeloblast look like?
Myeloblasts are typically large cells, usually 2 to 4 times the size of a red blood cell. They have a very high nucleus to cytoplasm ratio, meaning the nucleus takes up most of the cell. But the most defining feature is the nuclear chromatin. It's very fine, delicate, and open, often described as lacy. It looks smooth, not clumpy like a mature lymphocyte. You can also usually see one or more prominent nucleoli, which look like little pale bubbles inside the nucleus.
And then there's the cytoplasm. It's typically a moderate amount, standing a light gray-blue, but sometimes hiding in that cytoplasm, you find the single most important morphological clue in all of leukemia diagnosis.
Ah, yes, the pathognomic finding, the hour rod. Tell us about hour rods. What are they, and why are they so important?
An hour rod is a needle-like reddish-pink inclusion found in the cytoplasm of myeloblasts. They are essentially abnormal fusions of the primary azurophilic granules. Finding even one definitive hour rod is a game-changer. Why? Because it tells you unequivocally that you are looking at a blast of myeloid origin. Lymphoblasts do not make hour rods. So if you see a blast and it has an hour rod, you can immediately say this is AML, not ALL, acute lymphoblastic leukemia. It's the single most critical morphologic distinction we can make on a smear.
It locks in the lineage. So you're scanning the smear, you see these blasts, maybe you're lucky enough to spot an hour rod. You're also confirming what the analyzer told you. You see the anemia, the thrombocytopenia. You scan for any mature neutrophils, and there are hardly any. The diagnosis is highly suspected, but morphology alone isn't enough. We need to confirm it and classify it. This is where the bone marrow biopsy and ancillary testing come in.
Right. The hematopathologist will perform a bone marrow aspiration and biopsy. They're looking to confirm what we saw in the smear, a marrow packed with blasts, and to get that official 20% or more blast count. But they also send samples for a battery of tests that help us nail down the exact type of AML. We can start with the classic old-school tests, cytochemical stains.
We don't run them as often in the routine lab anymore because flow cytometry is so powerful, but it's crucial to know the principles. The most important one is myeloperoxidase, or MPO.
MPO is an enzyme found in the primary granules of myeloid cells. So you apply the stain, and if the blasts are of myeloid origin, they will stain a strong brown-black color. MPO positivity is another definitive marker of myeloid lineage. It's essentially the biochemical equivalent of seeing an hour rod. Sudan black B, or SBB, works similarly, staining lipids in the granules, so it gives a similar staining pattern.
And then you have the esterase stains, which are fantastic for differentiating the granulocytic blasts from the monocytic blasts. Specific esterase, naphthol ASD chloroacetate esterase, or CAE, is positive in the neutrophil line. Non-specific esterase, alpha-naphthol acetate esterase, or NSE, is positive in the monocyte line. If you have a leukemia where both stains are positive, that points you toward a diagnosis of acute myelomonocytic leukemia.
These stains are classic, but the modern workhorse for lineage assignment is flow cytometry. This is where we get incredibly specific. Can you walk us through how flow helps us diagnose AML?
Absolutely. Flow cytometry uses fluorescently tagged antibodies that bind to specific proteins, or CD markers, on the surface and inside of cells. We create a cocktail of these antibodies, run the patient's sample through the instrument, and a laser detects which markers are present on the blast population. For AML, we're looking for a characteristic pattern.
So what's the signature? What markers scream myeloid blast?
First, you look for markers of immaturity, the blast markers. These are typically CD34 and HLA-DR. Then you look for the specific myeloid lineage markers. The most common ones are CD13 and CD33. Another really important one is CD117, which is a marker for early myeloid progenitors. So, a classic AML immunophenotype would be a population of cells that are positive for CD34, CD13, CD33, and CD117. We can also stain for cytoplasmic MPO by flow, which is extremely sensitive. This combination of markers confirms the diagnosis with a high degree of certainty.
It's incredible how specific we can get. We've gone from a flag CBC to morphology to a definitive lineage assignment. But the story doesn't end there. In the modern era, just saying AML is not enough. The diagnosis, the prognosis, and the treatment all hinge on the next level of testing, cytogenetics and molecular studies.
This is the heart of the modern WHO classification system. It's not just about what the cell looks like anymore, it's about what is broken in its DNA. The biggest and most important category is AML with recurrent genetic abnormalities. These are specific chromosomal translocations or gene mutations that define a unique disease entity.
Let's talk about the most famous and infamous one, AML with the translocation T1517. This is acute promyelocytic leukemia, or APL. This isn't just a subtype, it's a completely different beast.
It really is. APL is a true medical emergency. Morphologically, the cells aren't typical blasts, they're abnormal promyelocytes, often with a distinct bilobed nucleus, and the cytoplasm is absolutely packed with coarse, bright red granules. They're also famous for having multiple hour rods bundled together, which we call faggot cells, an older term that has stuck in the literature.
But the real danger with APL isn't the cell itself, it's what's inside those granules. The granules are loaded with procoagulant and fibrinolytic substances. When these fragile cells break down in circulation, they release this material and trigger disseminated intravascular coagulation, or DIC.
And this is a huge connection for the MLS working across different departments. The hematology laboratory scientist sees the abnormal promyelocytes. At the same time, the coagulation laboratory scientist is getting stat calls because the patient's PT and APTT are through the roof. Their fibrinogen has crashed to undetectable levels, and their D-dimer is sky high. This combined picture is classic APL-associated DIC, and it can cause life-threatening bleeding and clotting simultaneously. Rapid recognition by the lab is literally life-saving.
It's one of the best examples of the lab's direct impact on patient survival. The reason is that the translocation T1517 creates a specific fusion gene called PML-RARA. This rogue protein is what causes the maturation block at the promyelocyte stage. But amazingly, it can be targeted. A drug called all-trans-retinoic acid, or ATRA, a derivative of vitamin A, can basically force the cells to overcome that block and mature. If you identify APL early and start treatment with AUTRA, it goes from being one of the most fatal leukemias to one of the most curable.
It's a true success story of molecularly targeted therapy. There are other important genetic abnormalities too. Translocations like T821 and inversion 16 are considered favorable risk AML. They tend to respond better to standard chemotherapy. On the other hand, finding abnormalities in chromosome 3 or complex cytogenetics with many changes points to a very poor prognosis.
And then there are the individual gene mutations we now test for. A mutation in NPM1 without another mutation called FLT3-ITD is generally favorable. But if you have that FLT3-ITD mutation, it's a marker of aggressive disease and a high risk of relapse. These molecular results are no longer just academic. They dictate whether a patient gets standard chemotherapy or needs to go straight to a stem cell transplant.
So let's bring this all together. We start with a patient presenting with fatigue, fever, and bruising. The CBC shows pancytopenia with circulating blasts. On the peripheral smear, we, the MLS, identify large blasts with fine chromatin, prominent nucleoli, and crucially, we search for our rods. We make the critical call. This triggers a bone marrow exam which confirms 20% or more blasts. Flow cytometry shows a myeloid immunophenotype. And finally, cytogenetics and molecular testing reveal the specific underlying mutation which dictates the patient's entire treatment course and prognosis.
It's an incredible diagnostic cascade, and it starts with us at the bench. Our eyes on that initial smear are the gateway to this entire process. We are the ones who raise the first, most critical alarm.
And understanding the whole story from the pathophysiology of the maturation block to the clinical significance of a PML-ARA fusion gene empowers us. We're not just counting and identifying cells, we're interpreting a complex disease process and providing the foundational data for life or death decisions.
A perfect summary. We've tackled the fast and furious world of acute leukemia, where cells are frozen in infancy and proliferate out of control. But what happens when the problem isn't a hard stop in maturation, but rather a slow, smoldering process of making cells that are just wrong?
That's a fantastic place to leave it. We've covered the acute rebellion. Next time on the deep dive, we'll explore the world of dysplasia and ineffective hematopoiesis. We're going to unpack the puzzle of myelodysplastic syndromes, or MDS.
I'm looking forward to it. It's a fascinating and often challenging diagnosis. Until then, thanks for joining us.